Welcome to ICUDemy. In this module, we tackle restrictive lung disease, the opposite end of the spectrum from obstruction. Here the challenge is stiff lungs that are hard to inflate. In restrictive disease, lung compliance is low. The lungs are stiff, whether from edema, fibrosis, or loss of surfactant. Think of trying to inflate a brand new balloon that has never been stretched. It takes a lot of pressure to get even a small volume in. Because compliance is low, the time constant, tau equals compliance times resistance, is short. This means the lungs fill and empty quickly, but accept very little volume before pressure climbs dangerously. Let's compare the pressure-volume relationship. In a normal lung, a small increase in pressure produces a large increase in volume. The curve is steep. In a restrictive lung, the curve is flat. The same pressure produces far less volume. This is the hallmark of low compliance. Notice that to reach the same tidal volume, the restrictive lung requires much higher driving pressure, and that means a higher risk of ventilator-induced lung injury. Now let us see the waveforms. Here is a 20-kilogram child on pressure-controlled ventilation at a rate of 25. On the left, compliance is very low at 0.006 liters per centimeter of water, representing severe restrictive disease. Tidal volume is only 72 milliliters. On the right, after recruitment and surfactant, compliance improves to 0.015. Look how the tidal volume increases to 176 milliliters, even though the pressure settings are identical. In pressure control, improving compliance directly increases the volume delivered. The ventilation strategy for restrictive disease follows logically from the physics. First, use lower tidal volumes. Aim for 5 to 7 miles per kilo to protect the fragile alveoli. Second, increase the respiratory rate to compensate. The short time constant allows this. The lungs fill and empty quickly, so a faster rate does not cause air trapping. Third, keep the plateau pressure at or below 28 centimeters of water. In children with increased chest wall elastance, up to 29 to 32 may be acceptable. Fourth, use driving pressure as your guide. Delta P equals tidal volume divided by respiratory system compliance. The driving pressure tells you the mechanical strain on the lung and may be the best single parameter to optimize. Fifth, use higher PEEP to maintain recruitment and prevent cyclic atelectasis. Let's focus on driving pressure. It is the difference between plateau pressure and PEEP. Mathematically, delta P equals tidal volume divided by respiratory system compliance. In adults with ARDS, driving pressure above 15 centimeters of water is associated with higher mortality. In children, the evidence is limited, but keeping delta P below 10 for healthy lungs is recommended. The beauty of driving pressure is that it automatically accounts for both the size of the breath and the stiffness of the lung. If compliance falls and you keep the same tidal volume, driving pressure rises as an early warning. What causes restrictive physiology in children? Early PARDS, when the alveoli are flooded with edema and the surfactant is inactivated. Pulmonary fibrosis, chronic scarring that stiffens the lung parenchyma. Chest wall restriction, from abdominal distension, a large pleural effusion, or thoracic deformity. And atelectasis, collapsed lung units that reduce the effective compliance of the remaining aerated lung. To summarize, restrictive disease means low compliance and a short time constant. Use low tidal volumes, higher rates, and keep plateau pressure at or below 28. Use driving pressure as your guide to optimal tidal volume. Apply higher PEEP to keep recruited lung open. And always think about the cause, whether it is edema, fibrosis, chest wall restriction, or atelectasis, because that determines whether the stiffness can be reversed. That concludes our module on ventilating restrictive lung disease. Remember, the key is to protect the stiff lung, keep volumes low, pressures limited, and let driving pressure guide your settings. Thank you for learning with ICUDemy.